Hello.
Hi, Nicole. I'm your captioner for today. My name is Darian.
Hi, so you need the API token, correct?
Yes, ma'am.
Okay. That should work.
Thank you.
No problem.
Hi, Nicole. Your captions are set up. However, I'm not seeing the CC option for me. I don't know if other participants. Can you see it?
Oh, yeah, I see the CC option.
You do? Okay, maybe it's just me. Can you check for me and just make sure you see this is a test of the captioning software? Oh, maybe now. You know what? It just popped up. Oh, no worries. It just popped up. You're all set. Thank you.
Great. Thanks. Hey, Lisa.
Hey.
How's it going?
Going good. How are you doing?
Doing good. Excited for the talk.
Yeah. I just saw your Slack message, and yep, I have a little introduction blurb written up. So I'll just be going off of that for the introduction.
Yeah, so Dr. Van will just, kind of introduce like our group and, just the lecture series overall, and then she'll turn it over to you and you can introduce the speaker.
Yeah.
Good.
Mm-hmm.
Yeah.
So sounds good. And this is being recorded, right? And then it's being done. Okay, perfect. Awesome. Well, I'm gonna send a couple emails really quick, but I'll still be here. I'll just be muted.
Yeah, no problem.
Hi, guys.
Hello.
Thanks for having me.
Yeah, thanks.
Dr. Cejas. Okay.
Hey, Lisa, how should I introduce you? It's Stephanie. I'm doing the intro.
Oh, I'm fine with just being introduced as one of the committee members.
One of the committee members. Okay, you got it.
Hi, Dr. Cejas. I'll be introducing you at the beginning of the lecture.
Sounds good.
All right. Also, I have one question. So after the talk, people have questions or comments. Would you prefer people put them in the chat or unmute themselves? Is there any preference?
All right. However people feel most comfortable is fine with me.
All right, sounds good. We do have some people in the waiting room, so I don't know if anybody has any other questions or thoughts.
I'm sorry. Should I have a PowerPoint? I mean, I feel like I'm not going to stick to it like super closely, but should I pull it up now or just wait until everybody's in?
Whenever you want to. Let me just make sure I give you screen sharing access.
Okay.
Okay, I'm just gonna make you a co-host.
Okay.
There we go. All right. I'm gonna start letting people in from the waiting room if that's good with everybody. Okay.
Yeah, that's great.
All right. I just wanted to get us all started so we can get going and people can continue to trickle in, but welcome everybody. My name is Dr. Stephanie Van. I'm a Vietnamese female with long black hair up in a bun, wearing a dark blouse and a blazer, sitting in front of a blank wall. I was honored to be invited to give an introduction for today's event, continuing the Equal Access in Science and Medicine's lecture series. So I'm a new faculty member at the School of Medicine here at Hopkins. I actually did my residency in physical medicine and rehabilitation, and then I decided to focus on interventional pain management because it helps me feel very useful to a wide variety of people, no matter what they've been through. I can help them navigate their options. Even though I'm only a couple of years out of training, one thing I've already had a lot of experience with is just how much people tell me the healthcare system is inaccessible. Every day at work, people talk about how they don't feel listened to, or they don't understand why a certain plan was recommended, or they have a mountain of paperwork, or even maybe they're going through a lawsuit or other administrative challenges that exist for too many people. So it's important for healthcare to properly acknowledge and learn from the people it's supposed to be helping. I firmly believe this. Medicine is supposed to be a field of lifelong learning, but from my experience, people and systems easily get set in their ways. And it takes events like this and people like you to facilitate education, dialogue, and different perspectives to truly incite cultural change. When I first started at Hopkins at the beginning of this year, I immediately started looking for like-minded people who are passionate about accessibility and education, and I connected quickly with the leadership of EASM. And since then, we've collaborated to form an advisory board made up of disabled and allied students, faculty, and staff to help reevaluate.
Computer. So let Barry to remove my account, right? Remove my account.
Right.
And we read it.
Right.
What else you need?
Thank you. I'm almost done, I promise. So me and some of the members of EASM and other people, we've just formed a really nice group that's an advisory board. So we're working to reevaluate our School of Medicine curriculum so that it's more inclusive of disability medicine and anti-ableism concepts. So a little bit more about EASM. Equal Access in Science and Medicine has created a sense of community among students with disabilities here at Hopkins, providing resources and educational materials to support them in clinical and lab environments and advocating for policies that benefit them. EASM hosts this lecture series, which features the perspectives and work of scientists and clinicians with disabilities, chronic illness, and mental health conditions, with the goal of providing role models to trainees with these conditions and to highlight the barriers to access in science and medicine. I'm pleased to introduce one of the committee members of Equal Access in Science and Medicine, Lisa Young.
Thank you so much, Dr. Van, for that wonderful introduction. And we, on behalf of the committee, are very pleased to have noted neurologist, writer, and disability advocate, Dr. Diana Cejas, here with us today. To tell you a little bit more about Dr. Cejas' background, she is a pediatric neurologist in Chapel Hill, North Carolina. She obtained her medical degree at Howard University in 2010 and completed pediatric residency training at Tulane University in Louisiana. She also obtained a master's of public health in maternal and child health at the George Washington University, and then completed further pediatric neurology training at the University of Chicago in Chicago, Illinois. She is not only currently faculty in the Department of Neurology, but she's also faculty at the Carolina Institute for Developmental Disabilities, or CIDD, at the University of North Carolina at Chapel Hill. Her clinical and research interests center upon youth with neurodevelopmental disabilities, and she is also a very prolific writer of narrative nonfiction, which has been published in both literary magazines and academic medical journals. We are very pleased to have Dr. Cejas here with us today, and I'll let her take it away.
Okay, thank you for that introduction. It is so nice to be here. As mentioned, my name is Diana Cejas. My pronouns are she, her, hers. I am a Black woman. I have a curly afro, and I am sitting in front of a kind of what I'm calling my library, but it's just kind of a wall of a couple of bookshelves that's full of books. Also, just in case you can see her, there is a small calico cat that keeps trying to get in the screen from the bottom. So that might be something that y'all see, but I'm trying to keep her out of here. I have a PowerPoint presentation, so I'm going to try to see if I can share that. Not exactly the most technologically gifted, but we're going to see if this works. Here we go. All right. Here we are, and I am hoping that you're able to see my presentation, but maybe not my notes. Can I get a thumbs up if that's the case? Okay, fantastic. For once I did it correctly. But yeah, like I said, it's so nice to be here. Thank you for inviting me. So I'm a pediatric neurologist. I'm faculty of both the University of North Carolina at Chapel Hill and also the Carolina Institute for Developmental Disabilities. As mentioned, most of my work is within the world of disability in some aspect. The vast majority of my patients have some kind of chronic neurological or neurodevelopmental condition, plus whatever other kind of neurological condition you want to throw upon there. And in particular, I like to work with people with limited access to care. A lot of my research centers upon adolescence and the transition into adulthood and really how we can improve care for people with IDD and disabled young adults just in general. But before all of that, before I became a pediatric neurologist, when I was still in my third year of my pediatric residency training, I became first a cancer survivor and then a stroke survivor. And actually yesterday was the 10th anniversary of my cancer diagnosis. So you'll have to forgive me if I get a little bit weird, but I've been having a lot of feelings about that over the last couple of days. So today what I'm going to really talk with you about is I'm going to spend a little bit of time talking about that, but just a little bit of time because it's a very, very long story. I'm going to talk a little bit about my own illness, my recovery, survivorship, and what has helped me through that. And in particular, writing is one of the most powerful tools that I've had to help me through this on both a personal and a professional level. Writing is something that I see as a way for me to be creative, and also, as I'm going to speak about, a way for me to advocate not only for my own patients, but advocate for the disability community and getting better access to care for disabled people in general. So the thing is that I don't feel like I can really talk about my writing without actually showing you what it is that I do when it comes to the creative aspect of my writing. So with that being said, I'm going to try to see if I can read a couple of excerpts from some of the things that I've written that I kind of think bridge the gap between creative writing or narrative medicine and also disability advocacy and also just kind of disability narratives within medicine. That'll be sprinkled throughout this lecture here. And I'm going to start with one of my essays that is entitled Join the Club, just a very brief selection. First, I have no disclosures though. So she was in a car accident when she was 19 and it changed her whole life. That's the beginning of the bedtime story that my nurse told me 3 nights after the stroke. I'm a hard stick, so she had plenty of time to tell the tale. As she searched my arms for more cooperative veins, she immortalized herself, young and wild and carefree, living her life up to the hilt, right up until she got T-boned in that intersection. I imagined that she in her hospital bed must have looked an awful lot like me and mine, covered in wires and full of dread and feeling very small. I was a mess, she said, before. That accident was a blessing. She held pressure, counted to 10. Maybe this is too. She looked at me like she could see into my future. I looked at her and I drooled. I coughed. I tried to call her a liar. My tongue didn't work right and my brain didn't work right, so the words stuck right behind my teeth. As she buried my medications in flavorless applesauce, I pictured myself. Lifeless arm and wounded throat and ruined mouth. A horror. It was hard to see divinity in that. I was released from the hospital 8 days after my second surgery, 6 days after my stroke, and started living the recovery lifestyle. Fatigue and daytime television, therapy putty and pureed fruit. Every other day I went to therapy, physical, occupational, speech, or a follow-up appointment, oncology, neurology, otolaryngology. I spent an untold number of hours in waiting rooms. Time was distorted there, each room an almost but not quite replica of the one I'd been in a day or two before. The year-old magazines, the clock with a broken second hand, and the television that played hospital announcements on a loop were disorienting. Most of us waiting there were always, the people waiting there were always the same. Most of us were quiet, huddled over our cell phones, folded in upon ourselves. There was always a talker. The woman who was on her own cell phone loudly complaining about her husband, her children, or both. The man obviously waiting to see someone about a hearing aid, who recapped the day's news to his disinterested companions. They were war stories, not the kind with bullets, but bandages were involved just the same. Each person bearing the scars of their own battles with illness and injury. I distractedly thumbed through yellowed newspapers and listened to the tales told around me. Nutrition supplements and support groups, relapses and rehabilitation. I learned as much through eavesdropping as therapy. Contrary to what the television tells you, working in a hospital can be quite boring. When the patients are stable, when things are slow, the white walls and the smell of bleach and the ceaseless drone of the alarms from the vents and the drips and the pagers become tiresome quickly. To cut the tedium, people talk about patients, about the job, about each other, and stories spread like wildfire. So my little outline for this talk is that first I'm going to give you some more information about my relationship with writing. Then, because I'm a neurologist, I'm going to spend some time on writing and neurology generally, and like how writing is related to recovery after cancer, after stroke, after other kinds of neurological disease. I have a couple of resources that I can share if anybody is interested in learning more about any of those things, or getting involved in writing on your own and writing your way through your own kinds of recovery. And then I'm going to talk about how all of this is related to my career as a clinician, as a researcher, as whatever you want to call me as an advocate. And as we go, I'll kind of share a couple of bits and pieces from some of the essays that I've written. And I'm hoping that by the end of this lecture, you'll know a little bit more about how creativity can be an integral part of not only survivorship, not only part of your career as a physician, or a healthcare provider, but also how you can use writing as part of research, writing as part of, and creative writing as part of research, creative writing as part of your advocacy efforts as well. So that first piece that I read took me forever to write. And that was despite the fact that I had been writing for years. I have some examples of some of the things that I've written here on the screen, which I'll describe in just a moment. But it was 3 years before I could so much as touch pen to paper after my illness. And that was not for lack of trying, not later at least. It was just at first, I couldn't bring myself to write. And that was despite the fact that, again, I've been writing since I was a child. I actually got my very first publication when I was in the first grade. Our county school system put out a call for submissions and stories from elementary school students. And my teacher submitted a story that I had written about a trip to the zoo with my grandmother. I got, for surprise, and I had wanted to show a picture of that. I'd actually done a lecture about this before and keep wanting to show a picture of that very first publication, but my grandma has that book somewhere and she is not giving it up. So I guess I'll just have to show some of the other things that I could see here. Some of the pictures that I have on this little slide here are, I have a larger picture that is of a construction paper diagram or drawing, I guess you could say, of a very sick looking cell and 3 angry looking viral particles. The text on the page says that poor Mr. Cell got sick after he let the other mean nasty viruses out of his house. This was actually a pop-up book that I wrote for children when I think I was in 9th grade, maybe, all about mean nasty viruses and trying to explain to children what you have to do when you get a virus. Who knew that decades later that would be something that would be so pertinent to my career now. Some other pictures that I have here. I have one picture that is full of lots of colorful scribbles in pen ink of various colors and also pencil. You cannot read any of these little scribbles very well, but it's just lists and lists of different kinds of titles. And this was a picture of a journal that I kept when I think I was in high school and into my early college years. There's also a picture of a cover of a book that's entitled Appalachian Anthology. There's a picture on that cover of a figure who is painted in gold, blue, black, and white, who appears to be looking down. On the cover, it says a collection of short fiction and poetry written and published by Appalachian State University students. That's where I did my undergrad. And the last picture on this slide is a picture of the top of a story that I submitted. It says Diana M. Cejas. The title of the story is out here on the halo. Written on the top is a comment from my professor that I really still can't half read, other than the fact that it says very good writing and OK++. I'll just have y'all know that OK++ was like the highest grade that you could get in the class. So I was very, very proud of that when I got that at the time. I kept writing when I was small because I wanted to, and because poetry came easily to me between the fields of my family's farm and the wide open sky, and because an overactive imagination helped me put lyrics to my little sister's tuneless whistling, or turned a half of a daydream into a novelette, or a post-apocalyptic short story starring a plucky little heroine who happened to look just like me. I wrote children's pop-up books like the one that I showed here. I also wrote all kinds of other stories through college. As I said, you can see a photo of one of the anthologies in which my short stories were published, and this list of story titles and story ideas in glitter pen. I'm still terrible at titles, and I still keep track of them by trying to write them down in all kinds of random places. I kind of kept writing, imagining different worlds between lectures when I was in school and when I was in college, but it was in college where I was told that I had to choose. And my pre-medical advisor said that I couldn't do both. They said that writing was a waste of my time. My creative writing professor said, you know, biology and going to medical school, that was a waste of my time. My creative writing professor said, you know, you're really gifted. This is wonderful. You can keep doing this for the rest of your life. I got a C in organic chemistry. I founded a literary magazine. I published a bunch more stories. I wrote a play. I got an award for it. I was sharing it out, the writing that I was trying to do as much as I possibly could. But at the same time, I wanted to go to medical school. So I did what my advisor said. And I just got serious about my pre-medical studies. So that meant that I had to write. And that meant, that meant I had to give up writing. And that actually meant that it would be over a decade before I'd write anything other than notes on patients and, you know, anything other than an assessment and plan. On this side, I'm going to talk about this a little bit more. It's entitled The Other Background. I have 2 pictures that you can see first. The first picture is all the way to the my left side of the screen, which is a CT scan of a person's neck. where you can see that there is a very large white tumor on the side of that person's, right side of that person's neck. In the middle, there's a picture of an MRI where you can see a bright spot showing that that person has also had a stroke. So obviously something else happened that spurred me into writing again. This backstory is that during my first year of medical school, I found a mass on the right side of my neck. I went to our student health center after a couple of days of worrying about it. And there, one of the providers checked my neck, saw that I was young and otherwise healthy, and told me that it was probably nothing, just some minor infection that would go away. They told me to take a short course of antibiotics. And of course, I'm going to do exactly what they said that I would do. But that was the first of many visits to student health and repeated assurances that the lump on my neck was nothing to worry about. Years passed, the lump was still there, and it kept growing, kept getting told that it was nothing to worry about. I had multiple visits, multiple diagnoses of lymphadenopathy, and multiple courses of antibiotics, which eventually I stopped filling those prescriptions because I wasn't taking them. But still, I was told that there was nothing to worry about. The lump itself became hard, fixed in place, and had all of the warning signs that I was learning about in class. Still told that it was nothing to worry about. The lump became painful, and it was this kind of gnawing, constant pain that started as something small and irritating, but worsened to the point where I could not sleep some nights, no matter how exhausted I was. Still, I was told that it was nothing to worry about. By the time I got to my 4th year of medical school, I was on the ENT service for one of my rotations, and there I saw patient after patient with these lumps and masses that looked like mine. I was thinking about it literally every single day, but I waited until the very last day of the rotation to ask one of my attendings if he could kind of help me check it out, listen to what it was that I was saying. So, he did. He took a look. He did an exam, checked out the lump, smiled at me, and said, "It's nothing to worry about." So, like I said, it's a very long story, but all told, it took 5 years and more appointments and encounters with physicians than I can remember for me to get a correct diagnosis. I completed medical school and was halfway through my pediatric residency training before I could convince my new primary care doctor to get my very first CT scan, the one you see on the screen here. And it turned out that I had a carotid body paraganglioma, which is a kind of tumor that my doctors were convinced was benign. Only in my case, it wasn't. I had surgery to remove the tumor, and then after that surgery, that's when we had found out that it had spread locally. So that means, I had cancer. I had to go through that whole workup, see oncology, use surgeons. Initially, we planned to do another surgery, another procedure. I was going to have a modified radical neck dissection 1 month after my first surgery. Turned out, I think that my scans looked pretty good. My labs looked great. Again, I was young and otherwise supposedly healthy. So everybody thought that everything was going to be just fine. But during the second surgery, we found out how much that tumor had done. The tumor itself had kind of wrapped itself around my internal carotid artery. And during the first surgery, my vascular surgeon had meticulously peeled away the tumor and was trying not to damage that vessel. But what he didn't know was that because of how long the tumor had been there, the artery wall was already weak and unstable. So when my oncological ENT opened up the wound a month later, the way that he describes it is that he says that the artery had sprung a leak. He went to stitch it up, but the vessel fell apart at the first touch of his needle. So he controlled the bleeding while a vascular surgeon scrubbed in and took over. They cut out the damage, they put in a synthetic graft, and then sewed everything up, transferred me to the PACU, and waited. But during all of that, my vital signs have been completely stable. I woke up from anesthesia, I was following commands, I asked for water. Everybody thought that everything was fine, but then 12 hours later, I became confused. My face got very droopy. My left side was completely weak. And it turns out that the brand new graft had completely occluded. So I'd had a stroke. So they took me back to the OR, did another procedure to try to salvage what had happened, or salvage, I guess, basically the second procedure. Everything there was kind of very hazy for me. The next time I woke up was when I was in the ICU some hours later, intubated, sedated, obviously not able to speak or swallow, with my left side completely paralyzed. And there's another picture, and that's me. So this is actually me after I was discharged from the hospital one day after I got out of the hospital. In this picture, it's a picture of a Black woman with straight hair who's wearing some brown glasses and a pink night dress, and who is holding up her cell phone to take a bathroom selfie. She's smiling, but you can definitely tell that half of her face is very flat and droopy as she has just had a stroke. You can also see that there is a pretty big bandage on the right side of her neck, and she has a lot of different kinds of scabs and other wounds on that side of her neck as well. So I guess the good thing is that I recovered a lot of function pretty quickly, at least in my leg, although I still have some permanent sensory loss, weakness, and tone issues on the left side of my body, on my arm primarily. So after all of that, I just didn't really know what to do. At the time of my surgery, stroke, and subsequent hospitalization, I was a week into my 3rd year of residency, and I had plans. You know, I'd front loaded my schedule. I planned to spend most of the year trying to figure out what my career was supposed to look like. But now, not only was I trying to figure out how to get through residency and figure out the rest of my life, I was also trying to figure out how to be a patient and how to navigate medicine and the rest of the world in this newly changed, newly disabled body. Honestly, I was kind of lost, and I was unsure of myself, even though I felt like I had to prove myself. I questioned every single clinical decision, every career decision, every decision, even to the smallest things that I ever made. I asked my mentors, my doctors, my therapists, everybody for advice, and kept going and kept trying to act like I had it all together, but really all I was confused. So I have another little piece of a story to share. This is actually from one that was published in Neurology a few years back. This one is actually entitled Meat Slurry and My Particular Brand of Optimism. So the commercials were the worst. You never notice how many there are until you're not allowed to eat. I stared up at the television, stroked out and glassy-eyed, and marveled at it all. The way the milk splashes into the cereal bowl and scatters colorful oat rings, golden, gleaming rotisserie chickens, paired with mounds of creamy mashed potatoes, each topped by pools of velvet gravy, cheesy pizzas laden with spicy pepperoni, juicy burgers with crisp bacon and ripe tomatoes, ice cream and milkshakes and chocolate, everything called to me through the screen. The first thing that I got to eat after my stroke was a saltine, unsalted. It's safer that way, they said. I choked on tiny sips of water. I drooled, I coughed, I rasped my way through every conversation. I got a saltine. I bit it with the side of my mouth that still worked, and the white flour and iodized salt was like manna to me. Nearly anything tastes like love and sunshine on a 6-day empty belly. I finished 2 crackers and was cut off. I wiped the drool from my drooping mouth, closed my eyes, and dreamed of congri. Eating loses its shine pretty quickly when all you're allowed to have is dry crackers and bits of toast. It becomes a chore when chewing is exhausting and painful. That was one of the hardest things for me to deal with since I loved food so much. My baby stories are about peaches, my favorite, and hot dogs, my first word, and pork chops. That's a long story. I navigate cities by finding markets and restaurants. I lived in New Orleans, for goodness sake. But I had cancer and then a stroke, and I was left with a macerated tongue and nothing but 2 flavorless saltines in my one functional hand. I stared up at the television, surgical wounds itching and weak machines wailing around me, and lamented all that I had lost. We're going to advance your diet, they said, after I'd had 2 tests to determine how well I could swallow. As my body got a little better, I gained different foods back. Cups of sticky metallic puddings were followed by powdered eggs and hospital macaroni and cheese. We toasted my ability to climb 5 stairs with nectar thick fruit punch. I slowly, carefully ate half of a plate of overcooked noodles and chunky marinara sauce after I regained the ability to raise my thumb. It wasn't enough. I'd gone from an active, athletic young woman to an emaciated, defeated, discouraged girl in less than 2 months. I wanted my life back. I wanted gumbo back. It will come, my occupational therapist said, after I knocked over another cup with my toothbrush in it, after I dropped another therapy ball, after I broke another glass full of thickened tea. You can't get angry at yourself about these things. Your hand is like a baby again. Parents don't get mad at their babies for breaking things. I looked from her to my weakened hand, thought of every time I'd seen a parent fuss at their baby for doing just that, and scowled. One day, 2 bites into my apple cinnamon oatmeal made with real and artificial flavors, my speech therapist excused herself to check on one of the other stroke patients' breakfasts. I asked what they were having, and she pulled a face. Well, it's beef broth and thickener. Sometimes we put a little pureed meat in it, and then you just mix it all up and make a slurry out of it. I must have looked horrified. It's good, she said unconvincingly. Weeks of therapy went by, and then months. My walking improved, my speech got clearer, my scar started to heal. I ate d'auberge cakes and snowballs and red beans and rice. I only coughed a little. I only dropped things when I was tired. Every single time I knocked something down, though, or drooled in front of someone, or reached up and touched my scar, I thought of bad things first. There's a neurological ICU that my mind will always go back to when things aren't going right. But ultimately, even when I was at my lowest, my mind would wander back to that meat slurry. I think of what that other person must have been dealing with, how they might have coveted my boxed mashed potatoes and softened rolls. I think of that first saltine. I picture the smile that my occupational therapist gave me when she ran into me at a seafood restaurant 3 months after the stroke. I wonder what I looked like to her, a crawfish in each hand, a bowl of emptied gumbo before me, a determined look on my face. I broke another plate yesterday, and as always, I cursed my impaired hand and I looked at my impaired hand and started to curse it again and get angry at myself and cry. Then, as always, I swept up the pieces, took 2 deep breaths, and thought of meat slurry. Things can always be worse. So I'm a neurologist, so I felt a little compelled to throw neuroanatomy into this lecture and a little bit of information about linguistics as well, but I'm definitely not going to go into this very much. If you're interested in learning more about the subject, there's some really compelling work out there, particularly in the world of stroke and traumatic brain injury. But just to refresh everybody's memory, like extremely briefly, I just wanted to remind you that there are 2 parts of the cortex that are linked to speech. That's Broca's area of the inferior frontal gyrus, which is involved in speech production, and Wernicke's area of the superior temporal gyrus, which is involved in the comprehension of written and spoken language. But we all know that communication is more than just speech. It involves integration and comprehension of emotions, memory, all of that kind of coming together. And as such, there are lots of different areas of the brain that are involved in language. And what we think about creativity and creative writing in particular, we know that there are structures in both hemispheres that are involved in the generation of novel images, concepts, and phrases, though we don't quite understand the neurobiological steps that are involved in the creative process. Again, I'm not going to get into this too much, but I did think that it was really interesting to see that there have been lots of different studies about this. And in particular, there was a study in 2013 that specifically examined fMRI data during story generation. In that study, they took 14 healthy right-handed male and 14 healthy right-handed female participants who were about 24 years of age on average, gave them a text to read, told them to copy the first part of the text and then brainstorm a story related to what they read, and then write a new continuation of, basically write a new story to continue that original text. What the authors found is that there was brainstorming involved frontoparietal temporal brain activity while creative writing, which was associated with episodic memory, semantic integration, and free associative and spontaneous cognitive text production involved a left frontotemporal network. So I thought that was really cool. You should definitely check that study out if that's something that you're interested in as well. When I'm talking about creative writing, I just wanted to make sure that I provided a few different definitions to make sure that everybody's on the same page. I'm just talking about writing for this lecture, just because that is what I have my experience with. But seriously, the relationship between neurology, cognition, neural recovery, and the arts is fascinating. And there's wonderful work that's being done, particularly at Vanderbilt in their music cognition lab, if music is something that you're interested in, learning about the neurology behind that. And then also there's a brain and music lab at USC, excuse me, the USC Brain and Creativity Institute is doing a lot of different work. But when I'm talking about creative writing specifically, I'm talking about writing that focuses on narrative craft, character development, imagery, poetics. Those are things like fiction, your short stories, your novels, nonfiction, which I primarily write these days, which I write a lot of lyrical essays, some of which you've kind of seen some examples of, memoir and poetry. Expressive writing is a part of creative writing, and it focuses primarily on personal experiences and emotion, but punctuation doesn't matter. Subject verb agreement doesn't matter. What you're really trying to do is get your emotions kind of onto the page. The technical aspects of writing don't matter when it comes to expressive writing. And therapeutic writing is a kind of expressive writing, which is a kind of creative writing, where you're trying to process your thoughts and feelings as part of a therapeutic process or program. I've actually been involved in all of these forms of writing and have found that they have helped me, you know, from a creative perspective, and then helped me kind of figure out what I want to do with my writing from a professional perspective. Why do we write in the first place? Because it's fun. Because it allows us to develop writing skills, whether those are narrative skills or technical skills. It helps us process emotions. It helps celebrate someone's individual voice or character. One of the other great things about writing, just in general, if you're thinking about doing it yourself or recommending it to your own patients, is that writing is something that can be done by anyone, anywhere. You don't have to have special equipment. One of the things that I always tell people is that I actually write on my cell phone. I don't sit and type. I don't necessarily take notes. One of the accessibility features that I use here is that swipe keyboard, and that really helps me have to cut down because it's very difficult for me to type with two hands these days. But I can do kind of all of my writing on here, and it's very easy. So like I said, you don't really have to have special equipment, but if you have some accessibility features on some technology that you're already using, you can use that to do your writing too. Another thing that's a benefit of creative writing is that we know that it can be associated with improvements in mood, attenuated neuroendocrine responses to trauma-related memories. I had a little bit of information here about writing and neurorehabilitation, but particularly I had some information about therapeutic writing and how that's involved in rehabilitation for patients with all kinds of different neurological conditions. But there are specific uses for patients with language disorders that are required because of neurological disease. Also patients with memory disorders. Again, I'm not going to spend too much time on this, but like this is something I could talk about for quite a while. These pictures here, I feel like I have not been doing a good job of describing some of the pictures I've seen on screen, so I apologize. I'll make sure that the alt text is available. But there's a picture of, on the my left side of the screen, which is just some colorful lines that kind of look like figures in very different shades of orange, yellow, blue, and red, with a caption beneath it that says "Paths Remember People." On the right side of the screen, or on my right side of the screen, there is another picture that is very colorful that looks kind of like a swirl, with another picture of a smaller swirl on the inside. It actually looks like these colors are transposed. The bigger swirl is mostly whites and blues, with some speckled multicolored dots across it. And then the inside swirl kind of looks like it is basically the transposed version of that. So mostly black and white in different shades of gray. And these pictures were actually taken from an ethnographic study that was performed by a stroke survivor who was navigating the first few months into recovery. It's a fascinating article. That survivor develops these images and has their own kind of record of their survivorship in the first few months after they had their stroke. Highly recommend that anybody who's interested in this kind of topic kind of takes a look at it because it's amazing. So because I'm also a cancer survivor, I also wanted to have a little bit of information about writing in cancer. There has been a lot of work on how creative and expressive and therapeutic writing can be helpful to cancer survivors, particularly as they're navigating the first few months of survivorship. Also of note is that there are a few young adult and other cancer survivor writing groups. I'm actually involved in one, which has been just so helpful to me, and has really the goals of some of these groups are to help those survivors make social connections, help those survivors process the emotions that they might be feeling related to grief, related to illness, related to disability. One of the quotes that I particularly like that I've had here on the screen is that it says, when cancer patients focus on the medical at the exclusion of other facets of their lives, we believe that they miss critical opportunities to address the emotional and existential issues that would lead to intimacy with loved ones and closure. And there was another study that I had highlighted here in my notes that talked about a 4-week-long creative writing program for patients with cancer. They had some patients who were randomized into a traditional kind of a therapy program and others who were randomized into this more creative writing aspect of things. This age group was a little bit older. The average age was about 67.5. They had males and females that were included in the group. But what they kind of showed was that those who were in the creative writing arm of the study showed that they had more or felt like they were better able to process emotions, reported lower indexes of some mental health distress or some questionnaires that address mental health distress, and also felt like they were better able to express themselves and everything that they were feeling through this creative writing opportunity. So I have another little piece of another little story that I've written that I can share with you. This is actually part of a 3-part story that came out in Los Angeles Review 1 year ago, 2 years ago. And it's actually called a Convalescence Triptych, but this is just the first part. It's not that I wanted to make her cry. It's just that I could stand it before. My sister and I had terrible fights. They started as soon as she was old enough to talk, as soon as I was old enough to hit. The mission wasn't to make each other cry, it was to wound, to leave a mark on my skin, on her skin, to let her know, let me know who was in charge here. I am scarred to this day. When we were little, we used our hands, her fists, my teeth, a pencil, a bottle, a rock. When we were bigger, we used our voices, her ridicule, my derision, indifference, a lie, the truth. It all hurt just the same. There's a picture of us in our Sunday school dresses. My knees were ashy, her belly poked against blue taffeta. I slung my broken, casted arm across her neck and she clung to it. She held my hand. We wouldn't let go. We were 1 year and 9 months apart. Accident babies, the both of us. We are more alike than we care to admit. She is loud when I am quiet, softer where I have hardened myself. We fit together, even now. When we were little, we packed picnics for each other and the dogs and the cats and the cows, and we ate beneath the trees in the meadow. We stayed for hours. When we were bigger, we sang mostly John B., but sometimes Drew Hill and sometimes Johnny Hathaway, and one time In Sync, and we laughed ourselves breathless when our grandmother saw us. Sometimes I call her just to sing. We fought each other and no one else could hurt us. She is my sister. She is my tormentor and my protector. I am her sister, and I am hers. I am hers. So I told her first. Who else could it have been? I have known her all of her life. So I said that I had cancer. It was my neck that had been strangled, but it was her voice that faltered. It was her tears that fell. It was her heart that broke. It all hurt just the same. So when I got out of my pediatric training and went into my first year of neurology training, that was very difficult for me. At the time, I was working in a hospital that's both a comprehensive stroke center and a comprehensive cancer center. And as a child neurology trainee, we spent a year of time on adult neurology. So I had to spend a lot of time caring for patients with strokes like mine and disabilities like mine repeatedly. And it first brought up a lot of feelings, and a lot of them were not good. The health-related anxiety that I tried to suppress since my hospitalization came to the surface with a vengeance. And I really had to figure out how to deal with that. And I also had to deal with the other feelings that come up that are difficult, that are just due to typical residency things. But one of the things that brought me comfort and made me feel connected with someone was actually a moment that I shared with one of my attendings. At the time, I was chatting with one of my co-residents about how I'd had to practice driving after my stroke. And I didn't even notice when my attending came into the room before he started to speak. And he asked me, "How are you with movies?" I paused and I stared at him in confusion. He said, "I had a hard time with movies after my stroke. They never made me cry before." So my attending kind of sat down with me and told me stories about himself as a young man, painted a picture of his own stroke, told me about how his life was upended and then restarted, and how he went from physician to patient and back again. And it was his story, but I felt like I knew all of the words. Back when I came to the wards, I really started to spend more time getting to know my patients. I'd ask how they were doing and talk about how their illnesses affected their daily lives. And I noticed that so many of my disabled and chronically ill patients had really similar stories. The physical and mental health conditions weren't always the things that caused them the most trouble. It was the fact that they couldn't get accommodations at work, or their mobility devices weren't covered by insurance, or they weren't able to access certain restaurants and shops, or they relied on inconsistent public transportation, or they couldn't get married because their disability benefits would be denied. And there was so much more. So there were so many patients also who were labeled as non-compliant because they weren't able to afford expensive treatments, or they were told that they were difficult because they questioned our management plans. And there were so many young women, especially young women of color, who were dismissed. Their symptoms were told that they were just due to anxiety, or they were told that it was some functional problem. As I'm hearing all of this, I started to kind of realize something. And I remembered every single interaction that I'd had at every institution that I'd been to since my illness, and really since I first noticed my lump. I had to fight to get dictation software when I literally could not physically type my notes. I had to fight to get a doctor to listen to me and get that first CT scan in the first place. Someone that I really respected complained that I was getting special treatment because I left an hour early after finishing up my work to go get a PET scan. It had taken me 5 years to get my correct diagnosis in the first place. I would see my patients hear their stories and recognize that basically I was my patients. So I have another little piece of something else that I've written here, which was a piece that I wrote for MedPage Today last year, I think. Their stories are all different. There was the boy with cerebral palsy who just wanted to play Little League, the teenage girl who'd had a stroke who wondered if she'd ever get used to her new crooked smile, the kids with migraines, those with anxiety or medical trauma who were terrified of talking to me at first. Some of them with neurological conditions from illness or injury, most of them with conditions that they were born with, encoded in their DNA. Each child had come to me for care. At some point during our first or 15th appointment, I turned to them and told them a secret. Their doctor had a disability just like they did. Each child was different, but the looks that they gave me in those moments, their smiles, their admiration, their relief, were always the same. I'm a physician, a pediatric neurologist at a busy academic institution. I care for children, adolescents, and young adults with epilepsy, headache disorders, cerebral palsy, autism, and a variety of other chronic neurological and neurodevelopmental conditions. I'm also a young adult cancer survivor and a stroke survivor, disabled. It took a while before I felt comfortable using that term to describe myself. I had to work through a lot of internalized ableism, including the many negative perceptions of disability I'd learned throughout my medical training. But luckily, I ended up in disability-centered spaces, working alongside other young disabled people who supported me as I educated myself on disability and identity, disability history, and the disability rights movement. And in those first few months after my illness, I also met other young disabled physicians, fellow cancer or stroke survivors who told me about navigating residency training and illness, other migraineurs who'd also hid their symptoms, those with medical trauma navigating working within a system that hurt them, like it had hurt me. Just as quickly as I connected with other disabled physicians, I also figured out how rare it was to see a doctor openly speaking about their disabilities, especially when it came to how these disabilities affected their relationships with patients. After I had that realization while I was still in training, things really started to change for me. I knew what it felt like to be on the other side of the bed. I knew what ableism and racism felt like and how that felt when it was coming from physicians. I knew that then I really could not shut up about it. So initially I'd gotten into medicine because I really just wanted to help people. How could I not speak out if I knew that there was something that we could do to try to see if we could improve people's care? So first, I started getting involved with some quality improvement projects that really focused on improving communication between doctors and patients. In my own continuity clinic as a resident, I worked with our social worker and our nurses to figure out a way how to not only treat seizures and other acute neurological issues, but also to better identify and address unmet needs that affected their health. I was one of the first pediatric neurology trainees that participated in the Illinois Leadership, Education, and Neurodevelopmental and Related Disabilities, or LEND program at the University of, that was at UIC, University of Illinois at Chicago, which is a national program that I highly, highly recommend to anybody who wants to care for children with disabilities. There, I learned more about interdisciplinary care and the power of patient narratives and advocacy. Like I said, I've been writing since I was a child, but by that point I'd set it aside for years. I really just didn't want to think about my experiences at all until LEND, and I didn't write a single word until my 3rd stroke anniversary. That morning, there was something that just kind of got stuck within me, and I could not stop thinking about writing if I tried. I still remember I was sitting in the EMU with one of my attendings. I'm sure he was trying to teach me so much about an EEG and reading different kinds of studies. And I think that he thought that I was taking notes, but I really wasn't. I was writing an essay, which at first, you know, I kind of scribbled some things down and posted it on Facebook. One of my co-residents really read it and pushed me to think about, you know, expanding it and putting it somewhere else, really just kind of to shut her up. I ended up submitting it, and that ended up being my first published essay, which was actually published as a piece of my mind article in JAMA. Now, that's not too bad. I kept writing. Sometimes it was about my experiences as a patient. Sometimes it was about general issues that were related to disability in medicine. At this point, my writing has been found in high-impact medical journals, well-respected literary magazines, popular media, other kinds of websites and blogs. You can really find a lot of what I've been writing kind of everywhere. And a couple of my stories have been anthologized in different kinds of collections, including this one you can see a picture of on my right side of the screen, which is Disability Visibility, First-Person Stories from the 21st Century, which was edited by Alice Wong, an amazing disability advocate in her own right. I highly recommend that you check out the rest of these stories. Also on this slide is a picture of me standing and talking in a red dress, standing up at a podium that says the Society to Improve Diagnosis in Medicine. I was actually invited to speak there to kind of talk about my own experiences, but also as part of a legislative day where we were specifically coming to DC to talk to our legislators. This was actually before the pandemic. To talk about how to improve diagnosis and access to care for people with chronic conditions and other disabilities. For the left side, there's a picture of 4 people on a Zoom call, including me sitting in front of this exact same bookshelf, and then 3 other people. At that time, we were talking, I believe that this was another talk about disability-focused issues and how we as clinicians could do better to address ableism and improve care for our patients. And then at the bottom of the screen is a picture of that cover of that first issue of JAMA where my first essay was published. So all of this writing started to lead me to make more connections, particularly in the world of disability rights and disability advocacy, which in turn has led me to make more connections and be able to again, work with legislators to try to see if we can't get better care for particularly marginalized members of the disability community. And by that, I particularly mean Black and Brown people, and also members of the LGBTQAI+ community. So I've been able to work at both the state and the federal levels. I am somehow, and I'm going to switch to the next slide here, somehow all of this ended up to me being very loud and obnoxious on social media. On this slide, you can see there's a picture of a tweet, which had gotten a lot of traction. The tweet is from my personal Twitter account. It says, "Parent, I think she fakes it to get days off. Me, pediatric neurologist and migraine extraordinaire. What does she do when she gets a headache? Parent, lays down in a dark, quiet room. Me. And parent, throws up. Me. And parent, cries herself to sleep. Me. Parent. Me. Parent." she gets a whole day off. So actually I did I do a lot of threads that are kind of educating parents about, again, these perceptions of what disability and what it means to be disabled, what it means to be a chronically ill child, and how we're not faking our symptoms. We need help too. And this was me speaking as both a neurologist and a person who's had migraines since she was a child. Also on here, you can see a couple of other pictures of some of the other writing that I've been doing and some of the other kind of talking that I've been doing about all of this stuff. A picture of me. I've done a couple of podcast episodes now. I highly recommend anybody who's interested, take a look at the Docs with Disabilities podcast. There's one picture here of me and also the University of Michigan University of Michigan Medical School Family Medicine Docs with Disabilities podcast logo. There's a picture again of me in a red shirt sitting in my living room with the title Misdiagnosed, Doctors Dismissed the Lump on My Neck. It turned out to be cancer. That was actually a series that I did as part of Health Magazine's outreach about, again, ableism within medicine, dismissing particularly young women's perspectives in medicine. Excuse me, a picture that shows two people shaking hands that says to thrive, Black and Latinx physicians need the communities. That was an article that came out in STAT. I had some articles that have come out in Psychology Today talking about what do doctors learn about disability, and then some logos from MedPage Today, the Huffington Post and STAT, again, where you can find some more of my writing. So I don't know where I thought I would be at the time of my diagnosis, or even when I was still in training, but I did not think that all of that would lead to all of this. But I think that what it has really shown me is that, one, writing is something that's always been kind of important to me. It's also always been my creative outlet, and it's always been a way for me to just get news out there. What I'm really trying to do with any of this is just trying to make it so that the healthcare that we provide to people with disabilities is anti-ableist, anti-racist, and it's as high quality as we can personally and structurally provide. That's really all I'm saying with everything that I write and everything that I do at this point. I really am working in my dream job at this point. I get to write, I get to do research, I get to do the doctor, and all of this has really come because I kind of found my voice and found a way to use it in a creative kind of way. Medicine's really hard, especially for those of us who are in marginalized groups and those of us who have faced adversity. The system is not built for us, and we know that, but now I think that I know that it's possible for it to be changed, even if it means just chipping away at things little by little, and even if it means that sometimes you have to do it in a creative kind of a way. I think that's all I've got. If you want to read any of these essays, like, please let me know, feel free. I think a couple of them might be behind a paywall, but that's cool. I can just send it to you if there's something, if you're interested in something. So I know we're running up on time, but sorry, I'm long-winded. Any questions? And I will look and try to see if there's anything in the chat. Let's see. I'm just seeing lots of thank yous. Thank you for thanking me, and thank you for including me in this topic and this conversation today.
Well, thank you so much, Dr. Cejas. And one question I do have for you is, what is a project that you're either writing or clinical research that you're most excited about that's coming up for you in the future?
Oh, so right now, geez, first of all, don't do what I'm doing and do too much all at once. The biggest thing that I'm working on an essay right now, which I'm hoping is going to be coming out soon, that talks a little bit about how specialists can be involved in advocacy outside of our specialties. So particularly thinking about not only reproductive rights, but also thinking about what's going on with gun violence. Some people think that neurologists shouldn't necessarily be talking about those things, but no, we absolutely should. So I'm writing something about that. Bigger, more broadly. I am, if I keep saying it, then it means it will be true. But I'm trying to see if I can't come up with that or finish my draft of what basically amounts to a memoir and essays that talks about my own personal experiences, and then historically racism and ableism in medicine and how that affects general health of marginalized groups. From a research perspective right now, I'm super excited. because we recently got funding. So my research again is on improving care around transition, healthcare transition, so going from pediatric to adult care. I'm working with one of my co-PI, who is Blaise Morrison, who is one of our researchers here at UNC, to really kind of look at experiences with healthcare transition, particularly among Black and Brown, LGBTQAI+, and other multiply marginalized people with intellectual and developmental disabilities, and really working with them to develop a theoretical framework for how we should be doing this research and how we should be involved in community engagement. We just got PCORI funds. I think I'm allowed to say that we're funded now that they've actually sent us the information. So that's something I'm excited about too.
That's awesome. Congratulations on getting the funds, and looking forward to hearing about your future projects.
So thank you again for inviting me. I'm always happy to talk about this stuff. Oh, and it looks like somebody asked for my email, so I put my email in the chat.
Looks like there are a couple other questions in the chat as well.
Cool. Let me see. I can try to see if I can scroll up. I apologize. I see. How can medical students get started with narrative writing? Just do it. I mean, that sounds ridiculous, but I mean, literally, you don't have to have any skills to do this. You don't have to have like a PhD in literature. That's fine. You can just kind of take, like, if there is something that happened, something that you learned about, something that is interesting. Now, mind you, one thing that we have to be very mindful of as clinicians, if we're writing about like our own experiences, is know that there are some stories that are not going to be ours to tell. So we might see a patient and they have like what we call an interesting case. We want to talk about it. Might not be appropriate for us to talk about those things and write about those things, but we can certainly write about how that learning experience made us feel. We can certainly write about the other aspects of medicine where we're not taking someone else's story and telling it when they should have the chance to tell their own story. But again, write about whatever you want. If you want to write like short stories, write short stories. If you want to process your emotions, process your emotion. Literally, you can just start writing. Now, there are, again, some like writing groups that you can get involved in. There are certain universities have more focus on narrative medicine these days. So I would encourage you to look at your own university and see if that, that initiative is already there. And then there are some places where you can just kind of tag into like writers' conferences. There are lots of narrative medicine focused conferences that happen every year. Like there's one that the University of Iowa does. It's called I think the Examine Life Conference, where I think it's, for the last couple of years, it's certainly been virtual, but I think that they're going to continue to offer virtual options, which talk about like the craft of writing, talk about different ways that you can get involved in narrative medicine. So yeah, just if you want to write, do it. Be shameless about it. And it's totally, and that it comes to, if you want to write to get published, okay, cool. If you want to write just because you want to write, that's totally fine too. Just get started. Let's see. And then there is, let's see if I see another question. See lots of comments, which thank you for so many of the nice comments. I see, what is your wisdom for those of us who are just coming to terms with their disability, especially with it being visible in academia? Let's see, I think I have a lot of thoughts about this. First, I would say, especially if you are either newly disabled or coming to terms with being with a member of the disability community, first I would say, like, give yourself a lot of grace. I think that it's really hard to confront the fact that it's not necessarily hard to accept your disability, although sometimes it can be, because sometimes there are going to be lots of things that you have to get used to that are different about yourself and your body. But sometimes it's really hard to accept the fact that so much hardship that I think that disabled people deal with is due to ableism and other forms of discrimination, and how those things kind of all come together. So I would say, like, you know, it's probably going to be hard for you to unlearn some of those things. It takes some time. Nobody's expecting you to be like #1 disability rights advocate on day one. Like, that's not how that works. So I would just kind of say, one, give yourself some time to kind of process your emotions about your illness and your disability. give yourself some time to kind of learn a little bit more, not only about the pathology of your condition, but also just like see if you can't connect with other people who have similar lived experiences. See if you can't read things that other people who are disabled or who have your own condition or whatever, see if you can't read their stories. See if you can't, even if you're just going on Twitter to try to see if you can't connect with the disability community there. I mean, I know that some people like to, say that social media is really frivolous, but honestly, that's been a pretty big way that I've been able to connect with lots of different disabled physicians, medical students, and trainees. And it's been really kind of a lifeline for me because, sometimes it's really hard to find other people who kind of know what you're going through because there's so much stigma around disability within medicine, and particularly academic medicine. So I would say, first, take care of yourself, let yourself feel how you feel, start doing a little bit of work to try to unlearn some of the ableism that everybody has internalized. It's going to be one of the questions I think that I'm hearing here, which probably was not one of the ones that was said, was like really around disclosure. How much do I like share about my disability or myself, particularly within academics or academia? And I would say disclosure is also something that's always highly, highly personal. I think it is also a privilege that some of us have, myself included, where we can choose to disclose or not disclose. At this point, I can kind of pass as non-disabled if I want to. I don't necessarily want to, but people might not necessarily look at me and think, oh, that's a person who had cancer or a stroke. But some of my colleagues, with visible disabilities can't necessarily do that. So I would say, if we're thinking about like what it means to be someone with visible disability or someone with a disability at all in medicine, and what that means around disclosure, what that means about being safe and protected. The disclosure part itself is something that's, very personal, and you're going to have to figure out how safe you are and how safe you feel with being able to talk about it wherever it is that you are. But I feel like that's going to have me going down a completely long tangent. Which I can certainly speak about a little bit more, but I want to make sure that there are some more questions that I get to. So please, also, if you have other thoughts, I'd be happy to talk about that a little bit more too. Let's see, other questions. Can you speak about the intersection of narrative writing and medicine and its importance and role in public health? Yes. So initially, when I did my MPH in public health research training, I was thinking that I was going to be more of a survey girl. I did a lot of quantitative kind of studies, and I love surveys, don't get me wrong. But one of the things that I started to realize as I was listening to my patients was I was like, how can I use these stories in research? Which led me to getting more of an interest in quantitative and mixed methods training. So I was lucky in that the position that I'm in now gave me a lot of protected time, so that I could basically go back and get even more training, particularly in qualitative methods and mixed methods research. And really all of this to me I think it makes sense because I feel like I'm writing stories and talking about, telling stories about disability in a creative way. But now I can take my patients' stories or my subjects who are in my studies, I can take their stories, their narratives, reports from their focus groups, reports from our semi-structured interviews, take that data, code it, and then write it up in a way so that I'm presenting it as a qualitative study. Again, all this is storytelling. It's just storytelling in different formats. It's either storytelling as narrative or it's storytelling as taking this patient's life experience. And certainly, it's a story that's got a prompt, like my research question or whatever kind of things we developed for our focus group kind of outlines. That's kind of the prompt for their story, but I'm still taking that story and I'm gleaning different kinds of themes from it so that I can use that information to inform research. So I mean, at this point, I'm like a total convert over to qualitative methods. I think it's been a lot of fun to be able to do this kind of work where I'm just listening to people. And it's not to say that I don't still love surveys. I do. So I do, I'm still involved in some of those studies where we do both quantitative and qualitative kind of methods, mixed methods research. But I think that there's definitely room for overlap if you're interested in those two kinds of worlds. I think sometimes people think that it's either one or the other. Like I, first talked about with my own mentors and advisors, like you cannot do creative stuff and be a researcher too. Well, that's not true in medicine. You just have to get, you know, a little bit creative about it and do a little bit more kind of qualitative kinds of work. But I honestly, one of the things that one of my professors in my qualitative research courses kind of talked about was that you can get a lot of broad data, you know, from looking at it quantitatively. Surveys, you can do a survey of 500 different thousand people, but sometimes you can't get to that really granular, like this is this person's actual day-to-day life experience, without just getting them to just talk about their story and just tell their story and figure out a way to how to present it. So I think that that's one way that there's kind of this intersection between narrative medicine and writing. Storytelling. I mean, just look at our example of the pandemic and how public health messaging has been kind of a mess throughout this whole thing. Think about the stories that we tell as we are trying to communicate with our patients. Think about the stories that we are trying to tell as we're trying to communicate these broad health messages, not only to like small populations, but to like the entire country. There are lots of different things that you can do that basically involves storytelling. It's just storytelling about data or storytelling about whatever you're trying to tell in a public health kind of a message. Let's see. I see another comment question that says, I worry about writing about an invisible disability would affect my career and that potential employers wouldn't think I'm as capable as an able person. Have I ever faced that? Excuse me, yes. Again, I think that this idea of being visibly or vocally disabled in medicine is something that is not common. One of the things that was most helpful to me was that as I started to talk about my own experiences, my own disabilities more, I started to meet so many people, even people within my own institution that were disabled or had chronic illness, or maybe their partner did, or maybe, you know, it was their mom, their child, whoever. And the thing that I think was most striking was that there were so many times people weren't just like openly, like I would tell my story first and they'd be like, oh yeah, I have that story too. Because there's still so much stigma and shame around disability within medicine. And honestly, there is still particularly certain conditions that are highly, highly stigmatized. I mean, I'm thinking about people, you know, who have mental health conditions, psychiatric conditions, where there are not just, you know, social, I guess, ramifications to disclosure. There's also professional ramifications, like, you know, let's say that you disclose that you're going through an acute psychiatric illness. There are lots of people who get worried about the safety of their licensure, about being, you know, judged about whether or not they are fit to be a physician because of their mental health issues. There are real world effects and real world kind of risks that kind of go along with disclosing their disability. But, there's a lot of information, or lots of other disabled clinicians who are talking. If you want to connect with those stories, like just let me know, and I can try to see if I can make those connections with you. But have I kind of worried that my own employers wouldn't think I'm capable? Absolutely. Particularly since I think, especially when I first got sick and then learned that I couldn't do some of the, you know, manipulative procedures anymore, I was going to be able to just hang and do my work, do my job. But one of the reasons is because I want to train disabled physicians out here. Yes, we can still do the work. Yes, you know, we're here just trying to live lives and be disabled and be doctors and all that kinds of stuff too. And I have found, and maybe I've just been very lucky, that when I've talked to my employers, particularly as I've gone further up in training, they've been a lot more accepting of me than I would have thought. I think one of the things that has certainly helped me is finding someone who was higher up on the food chain, who had, you know, a little bit more, one, power and privilege, but two, also had a lived experience. I told the story about my attending who was also a stroke survivor, who talked to me when I was still a resident and was like, hey, let me tell you about all this kind of stuff. When I moved into my neurology training program, I remember being so scared to ask for accommodations because I had had such negative feedback about getting accommodations in my other program. And that's nothing to say that, you know, my program was just terrible or anything like that. It's just that there were really full in the face ableism that I experienced as someone trying to get accommodations for some of my physical limitations. So I was very scared about that. But I just kind of decided to be upfront with my program director and be like, hey, listen, you know, this is what I'm dealing with. I need accommodations because I can't always type very easily with just one hand. And I was just so nervous, but my program director, as soon as I finished talking, he was like, well, do you want to use the same dictation software I use? And I found out, you know, he has chronic neurological conditions and that there were other disabled or chronically ill attendings in the program. So when I would say I had to go to physical therapy, it wasn't oh, you know, that's ridiculous. It was, how do we get you out of here so that you can get your work done, you can get the learning that you need to get done, but still to be able to take care of this aspect of your health. So I think that, yes, it has been scary. Yes, I have faced those things, but the thing that has been most helpful to me is finding like advocates and allies wherever it is I am. People just kind of understand what it is that I'm going through. Oh, let's see. I'm trying to see. I see someone that has a comment about a book, Unquiet Mind by Kay Jemison. She isn't a woman of color. The book is slightly outdated, but she talks about having bipolar and treating mentally ill patients, or excuse me, people who are patients and have mental illness. Yay for taking a look at some of the word choices that you use. I don't know if anybody has any other questions, and I know that I tend to ramble, and we're definitely over time, but. And like I said, if anybody has questions, it's really hard, I know, to try to see if you can't navigate having an illness or a disability when you are in training and you're not exactly sure where to go. One of the things that's been great about me being able to do talks like these is that I get the chance to connect with students and trainees who are dealing with similar kinds of experiences. So I would always be happy, like, feel free to reach out and we can certainly set up a time and talk like one-on-one if that's more helpful to you.
Thank you so much, Dr. Cejas. I think, as you can see in the chat, your talk really impacted a lot of people and resonated with many of them. So thank you so much for joining us today. And we're so pleased to have you as a speaker.
Thank you.
All right. Yeah, so feel free to reach out with any questions and have a great rest of your day, everybody.
Have a good day. Thank you. Anything I need to do from here?
Thank you.
Nicole, did you want to say any last words or? Okay, I think maybe she stepped away, but yeah, so this is really great. Yeah, I think we have a plan to, you know, send up this recording if you're okay with that, and as with the captioning as well. But yeah, I think that's all from us. And you did such a great job today. Thank you.
Thank you. All right. Well, thanks for inviting me.
Of course, take care. Bye.
Bye.